Welcome to today's webinar, Cannabis Attitudes, Allergies, and Patterns of Use in Followers of AAN. This is a timely and fascinating subject. It aligns with the mission of Allergy and Asthma Network. We work daily to end the needless death and suffering due to asthma, allergies, and related conditions through a four-pronged approach of outreach, education, advocacy, and research. My name is Sally Schessler, and I'm Director of Education for Allergy and Asthma Network. It's my pleasure to welcome today's speakers to the webinar. Joanna Zeiger is raced as a professional triathlete from 1998 to 2010. She placed fourth in the triathlon at the 2000 Sydney Olympics and won the 2008 Ironman 70.3 World Championships in world record time. She is a seven-time Olympic trials qualifier in 3 sports: marathon, triathlon, and swimming. Joanna still pursues her passions for sports as a top masters runner. When she's not training for runners events, Dr. Zeiger works as a cannabis epidemiologist. She's the founder and CEO of Canna Research Foundation, a nonprofit organization. It's a consortium of researchers whose goal is to understand the role of cannabis patterns of use and benefits and adverse effects in various patient populations to better understand efficacy and safety of medical cannabis. The work of CRF is relevant to the cannabis industry, medical professionals, and patients. Through her company, Race Ready Coaching, Joanna works with endurance athletes of all ages and abilities and helps them reach their athletic goals with training plans that develop physical fitness and hone mental skills. Joanna's education took her to Brown University, Northwestern University, and Johns Hopkins Bloomberg School of Public Health for her PhD. Joanna's book, The Champion Mindset: An Athlete's Guide to Mental Toughness, was published by St. Martin's Press in February 2017. Thank you for being here with us today, Dr. Zeiger.
Thank you.
And Dr. William Silvers received his medical degree from the Indiana University School of Medicine, and his internal medicine residency was at Emory University Affiliated Hospitals in Atlanta, Georgia. He went on to complete his allergy and immunology fellowship at National Jewish Medical Research Center in Denver, Colorado. He is a clinical professor at the University of Colorado Health Sciences School of Medicine and a faculty affiliate at CU Center for Bioethics and Humanities. He received a Community Service Award from the Department of Medicine at the University of Colorado School of Medicine. He is chair of the International Cannabis Allergy KAP collaboration with the American College of Allergy, Asthma and Immunology, the European Academy of Allergy and Clinical Immunology, and the Canadian Society of Allergy and Clinical Immunology. His interests are integrative medicine, exercise-induced rhinitis, the skier's nose, cannabis allergy, immunology, and pulmonary correlates. Dr. Silvers was selected multiple times as a top doctor by his peers and is an avid skier, cyclist, and outdoorsman. Thank you for being with us as well, Dr. Silvers.
I thank you very much.
Today's program is going to have an outline, as you see here, with 3 major categories. We're going to look at the history of cannabis use in the United States. We're going to look at cannabis attitudes and patterns of use among members of Allergy and Asthma Network. And we're going to look at cannabis and allergies. And at this time, I'm going to turn the program over to Dr. Silvers.
Thank you again, Sally, and I thank the Allergy and Asthma Network for your support and for allowing us to share with you our work and the evolving nature of cannabis, medical and recreational, and the allergic and pulmonary correlates. Regarding the history of cannabis use in the United States, regarding the history of cannabis use in the world, it traces back really for the last 3,000 plus years, from China to the Middle East, Persia, Egypt, India, with literature describing uses ranging from textiles to medicines for indications such as rheumatic pain, constipation, menses. And the American production of hemp, which is really the same as the cannabis plant, and Joanna will go into this in greater detail, was encouraged really by the government early on for its commercial production, and was flourishing really until after the Civil War, when imports replaced hemp. As you'll see on the next slide, and I'm looking for Sally to help advance the slides. Thank you. It became a popular ingredient in many medicines, and was sold openly, really, in pharmacies by national companies. This one is a picture of Park Davis. Merck had it, and even from my hometown of Indianapolis, Eli Lilly was marketing tinctures of cannabis, and it was on the U.S. pharmacopoeia really until the Tax Act of 1937, when it was afterwards removed, and in 1970 was placed as a Category 1, Schedule 1 in the Controlled Substances Act. It was legalized first in California in 1996 for medical indications, and subsequently in Colorado and the state of Washington in 2012. And Colorado was the first out of the gate with commercial distribution in 2014, really, which is what stimulated my interest, because we were seeing more patients in our practice with allergic reactivity to cannabis once it was legal, and a greater liberal attitude toward this. Presently, just in the last few days, New York went recreational from being only medical. New Mexico is going that way, and it's now legal in some form in 36 states, of which there are 15 states that it is legal recreationally, including the District of Columbia. It's you'll see that in this picture that South Dakota, the ballot passed when legal challenges remain, but it was interesting in South Dakota that it went, usually the states went medical first, and then after some time, they legalized recreational in South Dakota. They went straight to recreational. On to the next slide. Joanna will begin speaking about the study that we had done in association with the Allergy Asthma Network on cannabis attitudes and patterns of use. Joanna.
All right, thank you. First, I'm going to give a little bit of background about cannabis. So one thing that I think people don't really understand or realize is that we have in our body something called the endocannabinoid system. And so the next slide shows sort of what that looks like. So we have receptors throughout our body, in our brain and in our body, that receive these molecules called endocannabinoids, and we have two of them, anandamide and 2-AG, and they bind to these two receptors, CB1 and CB2, and then there are metabolic enzymes that break down the cannabinoids after they're used. If there's some kind of dysregulation in the endocannabinoid system, then some disease states can take place. And so, you know, people think, oh, I just smoke cannabis and I get high. Well, the reason why that is because when you ingest cannabis, it actually binds to these receptors that we naturally have in our bodies. And so this slide shows you where the CB1 and CB2 receptors are located throughout the body. THC, which is the cannabinoid that people are most familiar with, and that's the one that's psychoactive, is expressed primarily in the brain, although you do see that it's also expressed, that it binds to the CB1 receptor, and you can see that it's expressed in the brain and throughout the body. And the CB2 receptor is a lot expressed in the gut. And with the CB2 receptor, CBD often binds more to that, but it also loosely binds to the CB1 receptor. So if you take THC and CBD together, sometimes that will take away that high that you feel because they are sort of fighting to bind to the same receptor. And also, if you're looking at what condition you want to treat, it's helpful to look at some of these charts to see which receptor you want to target, and that will help you decide whether you would like to use THC or CBD or some combination of both. One of the things that becomes very confusing to people is the nomenclature about cannabis. So cannabis is the name of the species of the plant. And underneath the species of the plant, you have hemp. And hemp means, by definition, that it has less than 0.3% THC. And that was made federally legal by the Farm Bill in 2018. On the other side, we have marijuana that is also considered part of the cannabis species. And that has much higher levels of THC, up to 15 to 20%, sometimes even higher. So CBD from hemp is not psychoactive, whereas THC from marijuana, that is psychoactive. Time when people purchase CBD, it's coming from the hemp plant, but you can get CBD from marijuana. It can be extracted from the plant. When people are purchasing CBD, because CBD is all the rage these days, and you can find it in anything from drinks to hamburgers to sodas to, you know, finding it at the grocery store or the pharmacy. The CBD is really the Wild West because it isn't necessarily tested in the way that it should be. THC has more stringent testing. So in the state of Colorado, if you want to purchase THC, it has to be tested through a state a state regulated lab to show that it has the amount of THC that it says it does, that it doesn't have any contaminants or heavy metals or pesticides or any other harmful products. And then when you go to the dispensary and you check out, you get a certificate or you get a sticker on there that tells you what's in it, and there's a certificate of analysis. CBD does not per se go through the same process, and so people can just buy it at the grocery store or online, and it isn't always third-party tested. And so a lot of times it can contain higher levels of THC than what's put on the bottle. It may not have CBD at all. It could have some other additive that is not listed. So if you're going to purchase CBD, make sure it comes from a very reputable source and that it's tested by a third party and has a certificate of analysis, and that it's very transparent of what you're getting. So why do people use cannabis? Well, there are a lot of benefits that have been shown through some studies. The research into cannabis is still fairly new. Historically, the research into cannabis has been looking at the negative effects of cannabis, how it can impact the brain, how it might impact driving, how its negative effects on adolescents, the gateway theory, which means that using cannabis would lead to the use of more harmful drugs, was the theory that people were going by for many years, has now been disproved. And so for a long time, it was thought that there were no medical benefits to cannabis, but now studies are showing, yes, there are medical benefits to cannabis, and some of them are listed here. It's helpful to cancer patients. It improves their nausea and their ability to eat. It's also beneficial to AIDS, HIV patients for the same reason, helps with nausea and eating. It helps with severe pain. It has been shown to help with seizure disorders. In fact, there is an FDA approved drug called Epidiolex that is a CBD product that is specifically for rare seizure disorders in children. And it can improve sleep, increase calm, and decrease anxiety. So these are some of the reasons why people use cannabis. But on the other end of the coin, cannabis also has adverse effects. It can cause hyperemesis syndrome, which is extreme vomiting. It can induce psychosis in some people. It increase appetite. So that's sort of a double-edged sword. For some people, an increased appetite is a benefit, while for others, that is an adverse effect. It can decrease your concentration. which is why there's the big concern about driving while under the influence of cannabis. Cannabis is known to decrease anxiety, but in some people it can increase anxiety, and there can also be respiratory and cardiovascular complications. So with the help of the Allergy and Asthma Network, we decided to conduct an epidemiologic study looking at attitudes and patterns of use among people who follow the AAN. Our goals were to find out patterns of use, what the routes of administration that cannabis users were using. Are they smoking? Are they vaping? Are they using edibles? Do they have liberal or conservative attitudes towards cannabis? What is their knowledge about cannabis? What is their frequency of use? And we also wanted to look at the adverse and beneficial effects of cannabis. And the reason why we wanted to do this is because we know that in the US, cannabis use is increasing in the general population and disease populations due to the increase in legalization, and because there is a perceived benefit for the symptoms of pain, insomnia, and anxiety, particularly with CBD becoming all of the rage. CBD I kind of view as cannabis light. That's how people sort of dip their toe in the water. They see CBD as not being as stigmatized as using THC, and so they start with CBD, may find some relief, may not find some relief, and then may end up adding some THC into their cannabis regimen. Cannabis use is poorly studied in allergic and asthmatic patients, a group whom the route of administration could have broad adverse effects. Smoking and vaping cannabis in this population could lead to increased symptoms of cough and wheeze, as well as increased use of asthma medication and exacerbation. The problem is that the short-term use of cannabis can act as a bronchodilator. So some people may be using cannabis for that purpose, but long-term use could be very harmful to the lungs. We just don't have enough information at this time about the long-term use of cannabis when people smoke and vape it. So AAN was incredibly helpful to us in designing and launching the study. We did our entire recruitment through the AAN via newsletter and social media and webinars. We did Twitter chats. We did webinars regarding cannabis. There was a lot of social media activity on Facebook, and newsletters with the links were sent out. The survey was completely anonymous and was open from May 7th, 2020 until September 7th, 2020. The questionnaire measured asthma control, asthma quality of life, and allergic disease status. We also had cannabis questions that covered duration and frequency of use, knowledge and attitudes about cannabis, benefits and adverse effects, and routes of administration. 489 respondents completed the survey. So I'm going to give you some statistics here. 18% of the 489 respondents indicated that they used cannabis in the past 2 weeks. 40.7% of the respondents were younger than 50, and 83.2% of the respondents were female. Of the respondents who did not use cannabis in the last 2 weeks, 2.5% said that they did not use cannabis because they were allergic to it. 50% of people with current asthma, 50% of the total respondents had current asthma, and 19.2% of the total respondents of the 489 people wanted to discuss cannabis with their allergist, and just under 34% of the allergists verbally or asked about cannabis on an intake form. So when we looked at the entire 489 respondents, we were able to divide them into 3 groups: current users, former users, and never users. And among those 3 groups, we then were able to look at their attitudes toward cannabis. Did they have a liberal attitude toward cannabis, meaning that they didn't think it was harmful to the brain, that they think it's less harmful than smoking, that they think it should be legalized both medically and recreationally. So those were some of the questions we asked. 95.5% of current users were fell into the liberal category, whereas never users, only 28.6% were liberal, and then former users fell somewhere in the middle at 59.2%. And this difference was statistically significant at p less than 0.001. The most common positive effects from cannabis use in those 18% who said that they used cannabis in the last 2 weeks were helps with sleep. So 75% indicated that it did help with sleep. 68.2% said that it gave them less pain and it calmed them down. And 67% said that it decreased anxiety. Interestingly enough, these percentages are very similar to percentages that we saw in a study we did in athletes. And these percentages are also very similar to what's been seen in other studies of both medical and non-medical patients. Because not everything is all rosy with cannabis and there can be adverse effects, we did ask about those. 29.5% said that it increased their appetite. 21.6% said that it increased their anxiety. 19.3% said that increased cough. And 15.9% said that they had difficulty concentrating. So even though there were some adverse effects in this group, these numbers are much lower than the beneficial effects. So some other results from current cannabis users. So these are the 18% who said that they used cannabis in the last 2 weeks. One of the things that surprised me the most about the study was that 53.4% said that they smoked cannabis and 25% said that they vape cannabis. And there is a little bit of overlap between this group of people who both smoke and vape. 61.4% use edibles. 58% of current cannabis users have asthma, and 50% of those with asthma have uncontrolled asthma, and they smoke and they cough. So this is a group that we're very concerned about. And 19.3% reported cough from cannabis, and that was regardless of whether they had controlled or uncontrolled asthma. They just would smoke it and they would cough. And then when we looked at cannabis knowledge, current users had 2.8 points out of 4, and that was more knowledge than former users that had 2.6 points out of 4, whereas never users had 1.8 points out of 4, and that was statistically significant at p less than 0.001. So what's interesting here is that current cannabis users have more knowledge about cannabis and they have more liberal attitudes about cannabis. So the conclusions from our survey are that a minority of AAN respondents currently use cannabis. So that was only 18% had said that they used it in the last 2 weeks. Half of current cannabis users with uncontrolled asthma reported smoking cannabis. A minority of allergists inquire about cannabis use, and a minority of patients want to discuss cannabis with their allergists. Positive effects were more common than adverse effects. And now Dr. Silvers would talk about cannabis and allergies.
Thanks, Joanna, and thanks for leading this this project. I might just say that this is really ground zero in terms of the knowledge base of the allergic asthmatic population and the use of cannabis, its effects and side effects. And we hope to continue monitoring this by evaluating the physicians and perhaps, follow up in the future to see as the evolution of cannabis marijuana use continues, what may be seen in our patient population. So This was really seminal work that was published in the Annals of Allergy, Asthma, and Immunology. What I'd like to address now are the respiratory and the allergic effects and the underlying immunology of cannabis. This is a review of the respiratory effects that was published by the Colorado Department of Public Health and Environment after recreational marijuana was legalized. Medical marijuana was approved in Colorado in the year 2000, legalized recreationally in 2012, and was sold by a dispensary model starting January 2014. While I had seen very few patients in my practice prior to 2014 complaining of cannabis allergies, I began seeing many more after it was recreationally available and had rather less stigma. So what we see here is that substantial findings have shown that the same carcinogens in marijuana smoke as in tobacco smoke, but what we have is that substantial evidence shows that you have chronic bronchitis with marijuana cannabis usage, with cough, wheeze, and sputum production. We have pre-malignant lesions seen in the airways, but interestingly, no lung cancer increase. And we know that it's an acute bronchodilator. This is substantial evidence. Moderate evidence shows that heavy use increases airflow obstruction, and there's limited evidence regarding increased particulate matter deposits compared to tobacco, bullous lung disease, and smoke from water pipes or bongs may contain more cancer-causing agents than just the smoke itself. This is, when I decided to address this area, I wrote a small paper on the Colorado allergist's experience with marijuana legalization, describing 3 case reports that I had seen, 2 of which were classic in terms of reactivity, in terms of allergic rhinitis, conjunctivitis, asthma, one also with contact dermatitis. And then the third was negative in terms of its skin test reactivity to the marijuana that had been dispensed by crude skin testing. And so there must be something else going on, and that's what really propelled me forward. I described it as a mild allergen at that time. And as you'll see with the next slide, we did a study thereafter of our own patients, over 100 patients, looking at the spectrum and prevalence of reactions to the marijuana in our practice, showing that of our patients who had never smoked cannabis, which was over half of our own patients, about 12% had reactions. Patients of ours who had smoked cannabis in the past, 26% had reactions, and patients who were actively smoking cannabis, about half of them had reactions. So to me, it was rather concerning in terms of documenting that the greater the exposure, the greater degree of allergic reactivity, addressing the harms in the allergy asthma population. Next slide, please. Getting down to the studies that are documenting this, as you'll see, the association of regular marijuana use alone or with chronic respiratory symptoms compared with non-smokers of any substance. And you'll see that there's an increase in cough, sputum, and wheeze, not so much in terms of breathlessness. Next slide, please. And interestingly, and fortunately, as we look at it, habitual marijuana smoking is not associated with chronic obstructive pulmonary disease. You can see that you have a lot of NS non-significance, in addition to a lot of NRs that are not reported, and only a few with increased symptoms. or changes in these pulmonary functions, attesting to their potential COPD. On the next slide, we'll see that marijuana smoking is also not associated with macroscopic emphysema. MS is marijuana smoke itself. MTS is marijuana and tobacco smoke. TS, tobacco smoke itself. NS is non-smokers. And as you can see, with the tobacco smoke is when we really see the macroscopic emphysema. With the marijuana and tobacco smoke, we may have an increase in some of the parameters. On the next slide, describing the lung cancer association, and as you can see, there's no increase in these studies looking at lung cancer, despite there being some pre-malignant lesions seen in the airways of cannabis smokers. Next slide, please. Getting down to the immunology, the CAN-S3 protein is a non-specific lipid transfer protein that is seen in cannabis plant, as well as interestingly seen in some fruits and vegetables, peaches, and what's called so-called stoned fruits, those that have pits and stones. You also have other proteins that have been associated with allergic reactivity within the cannabis sativa plant, especially the one called the oxygen evolving enhancing protein. And there's a little bit of difference now evolving in the presentations between the United States and Europe in terms of what proteins may be more important, but this is something that's being addressed by an international collaboration. So there are proteins that cause allergic reactivity. Interestingly, with the non-specific lipid transfer proteins, one can see a cross-reactivity between cannabis and certain fruits and vegetables, compared with a pollen food cross-reactivity, what we call the oral allergy syndrome. And one can test the in vitro proteins for peach, peanut, apple, as are described, that can tell you whether they're going to have the cannabis fruit vegetable cross-reactivity versus the oral allergy syndrome. So this is an evolving picture also. For diagnostic purposes, all that we really have right now is the crude skin testing from the cannabis plant that one can grind up, mix up, and test. But also there are certain blood tests, in vitro tests, that we can indirectly look at cannabis potential reactivity. On the next slide, I see that we're done. Okay, superb. So I just want to mention that we do have, as Sally mentioned at the introduction, for the past 2 years, we've been putting together an international cannabis allergy CAP, knowledge, attitudes, and practices collaboration with the American College of Allergy, Asthma, Immunology, the European Academy, and the Canadian Society, to where we're developing consensus statement, surveys, and diagnostic testing that can be developed so we can better address our allergic asthmatic patients as time goes on. So I thank you very much, Sally and the Allergy Asthma Network, and happy to address any questions you may have.
Great. Thank you so much, both Dr. Zeiger and Dr. Silvers. And we do have questions. So our first question is, could use possibly cause one to get asthma-like symptoms when they've never had them before?
I'll answer that absolutely yes. We've seen original presentations in patients, usually who have an atopic background, who have personal or family history of allergic reactivity to pollen, especially because cannabis is a weed, cannabis sativa, indica, and as a weed, it has the potential for the greater exposure, the greater reactivity. And we've had patients, such as I reported it with our initial report in the annals. One patient had come from Nebraska to get involved with the marijuana industry when it was medically legalized, had no previous history of allergic reactivity, was working in the grow operations, and we're seeing a lot more reactivity, actually, quite frankly, in the exposure to the grow operations. Had no previous history of personal or family allergic reactivity, but developed when he was working in the grows and then in the retail pharmacy, developed severe asthma, allergic rhinitis, etc. This was documented by skin testing, pulmonary function testing, and actually fractional exhaled nitric oxide, which is a very sophisticated test looking at inflammation. With treatment and greater avoidance, he improved significantly. So while one usually has an allergic background, personal or family history, one can de novo develop allergic reactivity to cannabis with its use, with its increased exposure.
Thank you so much. Our next question is probably one you both can answer, but I'll direct it towards Dr. Zeiger first. You spoke about sleeping and a decrease in pain and anxiety. Did you say that you saw the same percentages among athletes? Could you explain a bit more?
Sure. So we did a study prior to our study in allergic and asthmatic individuals. In athletes, we measured some of the same things, looked at knowledge and attitudes, adverse effects, beneficial effects, frequency of use, route of administration. So many of the same types of questions. And in this group of athletes, those who reported beneficial effects of sleep, improved sleep, less pain, less nausea, improved calm, less anxiety, the percentages were very much the same as what we saw here. And we also saw that the beneficial effects in that group also outweighed the adverse effects in that group. And things like inability to sleep and anxiety and pain are seen in multiple populations, whether athletes are supposedly healthy individuals, but they still suffer from many of the same things that the general population does. And disease groups have a lot of comorbid conditions for which they're using cannabis, as we're seeing here with the AAN study, that we've recruited them because they have asthma and allergies, but they are, a lot of them were using cannabis for medical purposes because they do have comorbid conditions.
Okay, a follow-up question. Is cannabis use acceptable for elite athletes? There's so many banned substances we hear about. And so the question is this able to be used by elite athletes?
The answer to that question is yes and no. CBD,
so many things in life, that's the answer.
Yep, I know, it's very complicated, but CBD is legal in all forms for elite athletes. THC is legal outside of competition. So if you got drug tested the week before a race and you had THC in your system, and it would have to be below a certain threshold, although that threshold is quite high, and in fact, they just raised it, you would not have a doping positive. If you got tested in competition and had THC levels in your blood, then that would be considered a doping positive. So elite athletes have to be very careful because it does take time for THC to leave the system, and every person metabolizes it differently, and how long it stays in the system is going to vary from person to person. And the amount of THC that it would take to reach that threshold level is also going to be very variable from person to person. And I also have a hypothesis that intense exercise actually releases THC back into the bloodstream. So even if you haven't used it in a period of time, exercise itself can release it. And there are a couple of studies that have shown that. So for elite athletes, really the, if you don't want to have a doping positive, your safest bet would be not to use THC at all, because then you would not be at risk. But I do know that a lot of elite athletes use THC and they take their chances, and many elite athletes have been sanctioned for THC.
Yes, it's so interesting. Okay, here's our next question. Is there as much allergy issue when people use edibles? It makes sense that anything inhaled may cause more issues.
So it looks like not as much. I would say that one needs to be a bit careful regarding hemp seed ingestion. There have been reports of anaphylaxis, of a systemic allergic emergency with this. There have not been any reports of deaths due to hemp seed or to edible consumption. On the other hand, the hyperemesis syndrome, increased vomiting, that it's been a problem with emergency room presentations. It's been well documented. But as far as allergic reactivity, the knowledge really still needs to be gained regarding this, but clinically, it does not look to be that way. The other thing is exposure, is topical exposure, especially with those who are working with the marijuana plant in the, as I described it, in the indoor grows, especially outdoor also. And then the potential is those who are growing at home, because, for example, with the Colorado laws, one can have up to 6 plants indoors, and not only are you dealing with the pollen that is in the air, but you're also dealing with the physical, touching the physical plant, which can cause a dermatitis.
And I should add, in terms of things like coughing and wheezing, in our study, people that were using edibles or tinctures did not report cough and wheeze at the same rate as people who were smoking and vaping.
I think I would have expected that, but it's nice to hear that it's substantiated. Someone is asking also, they're curious if you've looked at the effects on people in the household who have asthma, and they're thinking about children who are exposed to marijuana smoke by their parents.
Well, I will tell you, we know from cigarette smoking, passive exposure, and especially in the early years, will lead to a greater degree of allergic asthmatic reactivity. And given that, I would think that we'll see the same picture evolving from secondary exposure, from passive exposure with children. Also, not perhaps to the same degree, we'll see, but the model is there given our experience with passive cigarette smoke. And quite frankly, now we're even talking about tertiary exposure in terms of residue on surfaces within the household, within, with wherever the marijuana plant may be.
Okay, our next question is fairly similar. It is, what are the effects on the heart, lung, and other parts of the body when you're exposed to second and third hand cannabis smoke? This person lives in an apartment complex where one of their neighbors uses and can smell cannabis inside their apartment.
Right. So I don't know how well that has really been documented, but the potential is certainly there, as we know from secondary exposures. within the household. Within an apartment complex, I really am not familiar with that kind of literature.
Well, so many things have yet to be studied. Our next question is, do you see an increase in pulmonary involvement in COVID positive patients who are current or past users?
Not necessarily. In terms of COVID and asthma, fortunately, we have not seen a greater infection rate of COVID in the population with asthma. So that's a very important aspect. I might say that, with our Canna Research Foundation, which was really founded by Joanna, but fortunately we have her father, Robert Zeiger, integrally involved. And Dr. Zeiger is an MD, PhD, Harvard, Hopkins, National Institutes of Health, now in Southern California, doing epidemiologic research. He's also the associate editor of our Journal of Allergy, Clinical Immunology and Practice. So a lot of the data regarding the epidemiology, especially with the COVID pandemic in this past year, is being reported there.
Okay. Our next question is, people have mentioned that because of smoking cannabis, they no longer have asthma. Could this be true?
I'll tell you, the whole area of interest in terms of benefits, harms of cannabis has really been patient driven. And as they say, the plural of anecdote is anecdotes, not evidence. But as we, approach patient care in a more personalized medicine fashion, you need to evaluate individual patients. And given that that cannabis, that marijuana, really is an initial bronchodilator, it has longer-term irritant and allergic effects in the subject population. There are people that do, especially additionally given the anti-anxiety effect of cannabis for many patients. There are many patients that do claim to be improved with cannabis. My thinking is that inhaled, obviously, of any form, is not a good idea. Then the question is, especially if they have a medical indication, seizures, cancer, inflammatory bowel disease, glaucoma, whatever, would their concomitant asthma be affected? And, if it's given in an edible fashion, the answer is no, lesser. But one should stay away from the inhaled form. I think that's what we're coming up with.
Okay, great. Thank you. We have a parent who's writing and says they're confused. Should we warn our kids about cannabis, or should we allow them to consume at desirable measures when growing?
Well, I actually worked for 8 years studying cannabis in adolescents and young adults. And there is quite a bit of evidence that it can impact the growing brain. And so certainly, unless there is a serious medical condition and it's been discussed with a physician and there are really no other choices, then you really don't want adolescents using THC. CBD may be a totally different story. I mean, it's being used very successfully for seizure disorders and the like. But the recommendation right now is that adolescents and young and growing brains should not be using cannabis. If it's something that's needed, it should be thoroughly discussed with the medical team and should not be taken lightly.
And another point may be is that the growing brain grows into the mid-20s. So the developing brain, I should say.
Yeah,
And,
developing brain.
And I would say that along those lines, this is where it's important to address the benefits and harms. And that's what the one area regarding the developing brain that we really need to have longer term data. But that's an area really of great concern regarding adolescent use, and not only for the allergic population, but for all.
That's another fascinating field as well. Okay, our last question is going to be, clearly there are some people for whom this product could be a problem. Is there any kind of easily accessible, user-friendly screening that would help a prospective user evaluate the risk versus benefit?
Well, there really isn't a screening per se, but the mantra in the world of cannabis is to start low, go slow. So if you're a novice user, you would want to start with a very low dose, something that might be not even therapeutic, maybe 1 milligram of THC. And of course, you'd want to discuss with a medical professional to make sure it's not going to interact with any of the medications that you're taking and that it would be appropriate for you to use. And then once you start your cannabis use, you want to figure out what you're using it for. You want to define the use, because if you're just using it because I just want to use it and everybody else is using it, you're really not going to know if it's working. So let's say, for example, you're using it because you're having trouble sleeping. Well, you're not going to want to just jump right into using 10 milligrams of an edible. If you're a novice user, that could be way too much and make you much too high and have a very negative experience. And that person will never use it again, even though it could have been a great therapeutic option. So by starting slow and then dosing up very slowly until you get to that dose where, okay, I'm able to sleep, the adverse effects are either non-existent or they're totally tolerable compared to the fact that I'm sleeping fantastically well, is really kind of the approach that people take. So there is a little bit of experimentation that's involved, because I think more than traditional pharmaceuticals, people's ability to tolerate cannabis is just so variable. I mean, one person's 1 milligram is another person's 10 milligrams. Everybody metabolizes it differently. Some people just have terrible reactions to THC no matter what dose they're taking, whereas others find great relief from it. And same with CBD. Some people find that CBD is very relaxing and helps them, whereas other people don't find any benefit from CBD at all. So there is some experimentation that needs to take place. So the things that are helpful are to figure out why you're using cannabis, write down what it is that you're using, write down what your reactions were, because it's very difficult to remember from product to product what worked and what dose you took and at what frequency. And there are some apps that are out there to help you keep track of your cannabis use, what products you've used, what dose you took, and how it made you feel.
Okay, well, thank you so much, Dr. Zeiger and Dr. Silvers. We're so glad you could be here with us today.
Thank you so much for having us, Sally.
I thank you and the Allergy Asthma Network.
Thank you. Well, please join us for our next webinar, the Summer Allergy and Asthma Season Outlook. This will be on April 6th at 3 p.m. Eastern, and our speaker will be CEO Captain Bill Kirk from Weather Trends 360. You can register for this and any other one of our webinars at allergyasthmanetwork.org. Look for news and then webinars. Thank you again for joining us. This is Sally Schessler for the staff at Allergy and Asthma Network. Join us as we work daily so we can all breathe better together.